Okay. Assalamu alaikum. Good evening. I am Dr. Mohammad Zahid Hossain. I graduated from Dhaka Dental College in 1988, then obtained PhD from Japan 2001. And now I am working in the College of Dentistry at Najran University, Department of Preventive Dental Science, Division of Periodontics. I welcome you to join my lecture. This is really great pleasure that I, even staying abroad, I can communicate with my students in Bangladesh. I am really happy to share my knowledge with you. Today I want to discuss the periodontal pocket. As you know, that periodontal disease is very much common disease all over the world, and this disease affects mostly adult people, but young people, even early childhood also, people suffer. At any age, people can suffer, but mostly people suffer in the adult age. And this is a very slow growing disease, so people actually doesn't much aware about it. It starts as a little bad breath in the mouth. Sometimes little bleeding occurs during brushing. So usually people doesn't ever much. As we think that, oh, it is a simple thing, maybe it will be okay. But gradually, this gingival or gum disease starts to extend below the gum, and it affects our deeper structure. And you know that we have periodontium. We have mainly four structures. That is the gum or gingiva, periodontal ligament, cementum, and alveolar bone. Their four structure actually hold the tooth in the jaw, and the periodontal ligaments works as a cushion so that we can use our teeth during mastication, and for a comfortable mastication and as well as for the digestion of the food, the periodontal health is optimum. So to keep the periodontium healthy, we should know about this structure, about the disease that can occur around, and what are the consequences with this disease. So periodontal disease, when it starts as a slow with the gingival color change or a little bad breath from mouth, and sometimes little bleeding, sometimes little pain. Gradually it extends to the deeper structure, and then ligament loss, cementum loss, and bone loss. So this condition gradually extend if we don't care about it, or if we don't go to the dentist for treatment. Gradually tooth become loosened and it can exfoliate. So if anyone cannot take food comfortably, so he or she will must suffer from malnourishment, as because if we cannot take food with proper mastication, so we cannot deglute it well and we cannot digest it well. So as well as so whole our systemic condition will be deteriorated. So it means if we can't treat the periodontal disease, so automatically our health will be deteriorated and will be malnourished and will be suffer with many other diseases. And nowadays it become proved that periodontal disease can make any disease in the body. Suppose cardiovascular disease, coronary artery disease, chronic obstructive pulmonary disease. It can produce rheumatoid arthritis. It can produce preeclampsia, low birth weight babies, even uh, premature delivery. It can produce osteoarthritis. It can produce different types of cancer in the body, uh, lung cancer, spleen cancer, kidney cancer, okay, even colon cancer. So nowadays, it become proved that periodontal disease related to different types of systemic diseases, and we must aware about it. So we should have a clear idea, especially for the dentists who are going to be practiced, especially you, the people who are now in the third year and fourth year. So you must know about the periodontal disease as well in details, so that you can uh, practice well, you can make the patient satisfactory, and you can as well as the patient will be, I mean, healthy. And any treatment of the mouth, suppose restorative, prosthetics, orthodontics, everything needed periodontal knowledge. Without good periodontal, knowledge, no one can go for further treatment of any, the type of disease in the mouth. So, periodontium is the main part of our body, about dentition, that are utmost important to learn about it, and learn about it, the disease can occur, and learn about the treatment policies. So these are the parts you know already. The dentist who are in the third year, you know the parts and you know the functions as well. So I'm not going to discuss, just to have a little introduction at the beginning. Otherwise, maybe it will be difficult to understand what is the pocket. So this whole structure, the periodontium, it works as a single unit. If one part affected, the other parts also gradually affected. So we can think that this whole four parts, the cementum, periodontal alveolar bone, and the gingiva, become a single unit. Now see, this is a normal clinical picture, normal gingival. You can see the gingival color, contour, texture, if you touch it, you can understand the stipplings are there, no? And gingival size. So all things related to healthy condition here. So if you want to probe it to know how much gingival, sulcus depth, so you have to take a probe. You know different types of probe we use for probing. Um, uh, Usually we use University of Michigan O probe. That I think you know it. Though in our country it is not so standardized, as because the dental shops who sell the dental products and dental instruments, they don't know about it. So you have to find out according to the book. Especially we follow the Karanjas Clinical Periodontology. Now the latest one is Newman and Karanjas Clinical Periodontology, that is published in 2019, the 13th edition. I just made this lecture from that book. If you can manage that book, you can get the latest information regarding periodontology as well as the periodontal treatment policy. So you see, at first it starts with the gingivitis, a beginning. Then if you don't care it, or if we treat but we don't, much aware about oral hygiene care, it may aggravate gradually. It can produce periodontitis. Okay? So periodontitis is the condition that destroy our tissue, gingiva, ligament, cementum, alveolar bone. And you can also see the radiograph. This is an orthopantomograph, we call it OPG. You can find out that black spaces, these are called bone loss. Before it was here, but gradually bone loss, so these places become more wider. So periodontitis is actually a very bad disease if you don't care, or if you cannot treat well. So we should have a clear idea about what is periodontitis. And the beginning of the periodontitis, we should know the features. Main major features are two: the periodontal pocket and the bone loss. So today I'm going to discuss about the periodontal pocket. What is it and how it forms, the mechanism, how can you measure, and how can you diagnose the pocket, and how to the treatment policy. So what is periodontal pocket? First definition, you see, it is defined as the pathologically deepened gingival sulcus and is considered one of the most important clinical features of periodontal disease. It means, যদি বাংলায় বলি, যে আমাদের যে সালকাসটা আছে, যেটা আমাদের জিঞ্জিভা সিমেন্টাল জাংশনে যে অ্যাটাচমেন্ট থাকে, তো ফ্রি জিঞ্জিভাটা টুথের সঙ্গে একটা জায়গা তৈরি করে, স্পেস থাকে, এই জায়গাটাকে বললে আমরা ফ্রি জিঞ্জিভাল স্পেস, সেটা হচ্ছে জিঞ্জিভাল সালকাস। তো এইটা নর্মালি তো সাধারণত 1 to 3 মিলিমিটার আমরা নর্মাল ধরতে পারি। যখন এখানে ইনফেকশন হয়ে কোনো কারণে আস্তে আস্তে যখন এটা বেড়ে যায়, তো তখন দেখা যায় যে 3 মিলিমিটার বেশি হয়ে গেছে প্রবিং ডেপথ, তো সেটাকে তখন আমরা বলবো যে এটা পেরিওডন্টাইটিসে রূপান্তরিত হচ্ছে। ইট গো টু develop periodontitis from gingivitis. You can see this is a very big probe, maybe it is 12 millimeter. So it entered the whole, almost the probe inside the tooth. You see buccal surface, labial surface of the incisor entered. So no, it's a probe, sorry, it's the first premolar. So it means the pocket depth almost 11 millimeter as it's shown. So you have to measure the pocket from gingival margin as the base of the pocket, where the gingival probe tip stops. So you can get easily. It means the distance from the gingival margin to the tip of the probe where it stucks in the tissue. Now, sulcus versus periodontal pocket. Sulcus is normal, so I put it green color. This is normal, healthy. A pocket is a pathology, so I put it different color. So sulcus is the space between the neck of the tooth, as I told you earlier. Now, it is circumferential around the tooth, like a collar. Gingiva actually attached to the tooth like a collar around, as you have a collar of the shirt. So this collar is attached around this, and the gingival lower part attached at the cement-dermal junction. We call it junctional epithelium. So junctional epithelium, you can see the second part. Sulcus, when it depends with it become deeper. গভীরতে in periodontal disease due to apical migration of junctional epithelium. Junctional epithelium কি? এটা হচ্ছে জিঞ্জিভার ফ্রি জিঞ্জিভার বেজে যে অংশটা অ্যাটাচ থাকে সিমেন্টাল জাংশনের মধ্যে, সেটাকে বলে জাংশনাল এপিথেলিয়াম। এটা ফিউ মাইক্রো মিটার হতে পারে বা 10 to 12 সেল সাধারণত হয়। তো এটার আস্তে আস্তে ইয়ে হলে পরে ওই যখন starts the inflammatory process gradually destroyed, and then junctional epithelium become detached from the tooth and starts to form pocket. So usually for the normal periodontal, I mean the true periodontal pocket, you will find 3 millimeter, and if you see the radiograph, you will find that the bone loss is there. It means the junctional epithelium not attached to the seminal junction, it migrated towards root apically. You can see the both direction for the pocket can extend coronally and apically. So apically more and more deepen, then it will start to go up to the bone and then destroy the bone, and gradually it will detach the most ligament and cementum lost, and then it attachment loss. We call it clinical attachment loss. So this both way, so sometimes the gingiva can be enlarged along with the pocket form and the tissue lost, and gradually it will go towards the root. The classification of pockets, very important for you. How to classify? Usually we make it two types. One is gingival or pseudo or false or relative pocket. It means the pocket is started. It means when you insert the probe in the gingival sulcus, you will find that it is more than 3 millimeter. But how can we be sure this is a false pocket? Only if you take an X-ray. So X-ray will show whether there is a bone loss or not. If the bone loss is present, it means this is a true pocket. If the bone loss is not present, it means still the junctional epithelium attached to the cemental junction. So there is an actual periodontal tissue not lost. It means no loss of cementum, no loss of periodontal ligament, no loss of alveolar bone. So only the gingiva enlarged due to inflammation, due to drugs, different types of different types of medicine also can enlarge the gingiva. So this type of pocket we call false or pseudo or gingival or relative pocket. Another one is periodontal or absolute or true pocket. This happen when you will find in the radiograph that the bone loss is there, and your probing depth will be more than 3 millimeter. So in this case, it is a true pocket. Sometimes gingiva also can be enlarged, but if the cemental junction, the junction epithelium not attached there, so it means it's a true pocket. True pocket is called periodontal pocket, and false pocket is called gingival pocket. Remember this. So periodontal pocket also two types. One is suprabony or supracrestal or supraalveolar pocket. Another infrabony, intravony, subcrestal, intraalveolar pocket. Different types of name, but the same. But suprabony means the pocket you will find above the, you see this is still is a gingival pocket, as because still the junctional epithelium attached to the cemental junction here still. It is not lost. You see the bony structure, bony trabeculae like pyramid. Okay, but you see here it extended the pocket apically and also some bone lost, but still the pocket doesn't go below the bone, so it is above the bony margin, so it's called supraalveolar pocket. And second one is the infrabony. You see the pocket extend apically and it just bone loss is such a pattern that the pocket extend inside the bone and some part in the some portion of the pocket inside the bone. So it's called infrabony or intraalveolar or intravony pocket. And two types of these things you will find for the supraalveolar or suprabony pocket. The bone loss is horizontal. It's horizontal, and for the intrabony infrabony pocket, you will find the bone loss is angular or vertical. Very important to remember. Another thing that how can you measure? You see pocket depth from gingival margin to the base of the pocket when you insert the probe. Type 1, this is gingival pocket. Type 2, this is periodontal pocket but suprabony. Type 3, this is the periodontal pocket, true pocket, but intrabony or infrabony. You see? So actually very difficult to manage the infrabony pocket. We'll discuss in another class, maybe surgery. Now we'll just discuss the class, differentiation of the two types of pocket. Both are periodontal pocket or true pocket. How to differentiate? Suprabony pocket, the base of the pocket is coronal to the level of the alveolar bone. Intrabony pocket, the base of the pocket is apical to the crest of the alveolar bone, so that the bone is adjacent to the soft tissue wall. Understand? It means মানে পকেটটা এমন ভাবে হয়ে গেছে যে সেটা বোনের ভিতরে ঢুকে আছে, বোনটা একটা এমন ভাবে ক্ষয় হয়েছে যে মানে বোনের ভিতর পর্যন্ত পকেট দেখা যাচ্ছে, সেটা হচ্ছে ইনফ্রাবোনি পকেট। And the pattern of destruction of underlying bone is horizontal. It's horizontal bone loss, I told you earlier. And this is for infrabony, angular, vertical bone loss. Number 3, the transseptal fibers are restored usually, and it becomes the same pattern as it is. As because horizontal bone loss, so the pattern is still horizontal. But interproximally transseptal fibers, you will find this oblique pattern, as because the bone loss occurred by obliquely or vertically. And final one is the facial and lingual surfaces periodontal ligament fibers beneath the pocket follow the horizontal normal. So it means the bone loss in such a way the pocket extend and bone also lost, but never pocket goes below the bone. So in this case, the bone and the ligamentary structure, the oblique fiber, the fibers are the same course. But for the infrabony pocket, you will find that that is oblique course, as because the alveolar bone loss occurred obliquely or angularly. We have also another classification. We make it 3: simple pocket, compound pocket, and complex pocket. Simple pocket, it actually depends upon the sides. How many sides? You know, we measure a tooth 6 sides: mid-labial, mesiolabial, distolabial, mid-palatal, mesiopalatal, distopalatal, or mid-lingual, mesiolingual, distolingual. Okay. Even for the labial, you can say mid-facial, mesiofacial, distofacial, or mid-buccal for posterior teeth, mesiobuccal, distobuccal for the posterior teeth. So these 6 points usually measure for the pocket, and then we make it average for the each tooth, the probing depth. So pocket usually occurs simple pocket involve only one side. Usually we insert the probe and I move it. So if you move it, you can understand the extension of the pocket, how much. It's called pocket configuration. Depth and extension equal to pocket configuration. So while you insert the probe any side and then you extend mesially or distally. Suppose you entered the mid buccal. So after mid buccal and then you move mesially or distally, then you can understand how much extended. So if it involves two or more surfaces, it's called compound pocket. When third one is when the pocket starts one side, but it just follow a tortuous or a spiral route to the other side. This is called complex pocket. Usually it happens for the furcation containing tooth, you know, the molars and upper first premolar. So these molars and upper first premolar, you will find the furcation. So this type of teeth usually they show the complex type of pocket. Now, pathogenesis of pockets. This is a little difficult. You have to remember this, as because you know pathogenesis always you have to remember or memorize this. But if you can understand the things that what is inside, maybe if you get interest, you can remember this easily, or you can discuss with your friends together after getting this lecture. The initial lesion of the development of periodontitis, inflammation of the gingival response to bacteria. Usually, I told you that at first bacteria start to grow around the tooth, and there's periodontal plaque. So this plaque gradually they produce different types of their enzymes, they just deliver enzymes, toxins, and they take food, and they also excrete the metabolic end products. All are noxious, all are deleterious. I mean, all are bad for our health. So they destroy the tissue. Initially, it started, and you will find some color change of the gingiva, little pain, or some bleeding on. So this occurs initial lesion of periodontitis. You will find the pocket maybe more than 3 millimeter. These changes, very important to know that these changes sulcus to pathologic wall. So sulcus, we have a gingival crevicular epithelium. Crevicular epithelium, that is lines the internal epithelium, I mean the crevice of the gingiva. So this is normal, but when it becomes pathologic, we call it pathologic or periodontal pocket lining. So you should understand the difference of the gingival sulcus and the pocket lining. Pocket epithelium is pathologic. Gingival sulcus, the crevicular epithelium, is normal. Remember. So due to bacterial plaque, they produce such a condition, inflammatory reaction, and gradually the changes occur in the gingival sulcular epithelium, and gradually sulcular epithelium, gradually it becomes the pathologic periodontal pocket lining. So usually in healthy gingiva, you will find the coccoid type of cells or straight rods. Coccoid means coccus, circular, but maybe little elongated, not totally rod. This is called coccoid shape of cells. Different types of morphology of the bacteria. The periodontal disease actually occurs by bacteria. 99.99% occur by bacteria, and other conditions to our body, but sometimes it occur from our genetics also called as periodontal disease. Four cause. Periodontal disease etiology: local, systemic, environmental, and genetic. So this is very complex type of disease, periodontitis especially. So when there are other causes related to this, but when there is also plaque is more, disease will be more. So plaque is totally composed of bacteria. So we must know about the bacteria, what are related to healthy condition, what are related to disease condition. So disease gingiva, increased number of spirochetes and motile rods. Spirochetes, the helical type of bacteria. And this type of bacteria that can stand without oxygen, and that can grow without oxygen, and that can grow only in the protein-rich environment. So spirochetes, usually you find that the most lowest part or lowest layer of the dental plaque, you'll find spirochetes, and the deepest part of the periodontal pocket, you will find spirochetes. Suppose Treponema denticola, Treponema denticola is spirochete. This is very common. Treponema macrodentium. This type of bacteria you will find in the periodontal pocket, a deeper layer of periodontal pockets, and these are very tough bacteria. They are much pathogenic. And motile rods, the rod type of bacteria that can move. So these are also another type, very bad. Suppose Porphyromonas gingivalis. Suppose aggregative Bacterioctomycetium comitus. We simply PG, we call PI. AA. These are bacteria are very pathogenic, and they're very common for the periodontal disease, especially periodontitis, and you can find it abundant in the periodontal pocket. Now, pocket formation starts in the connective tissue wall of the gingival sulcus, and collagen fibers destroyed apical to junction epithelium. It means junction epithelium apical towards the root. Collagen formation destroyed, and inflammatory cells and edema you will find. So these places gradually, when inflammatory reaction occurs, our body immune cells, who are that? Our body immune cells, leukocytes, they come to fight with the bacteria. Bacteria actually is called antigen. So this fighting occurs between our body cells, immune cells, and the bacteria that enter our body to destroy our tissue. So these inflammatory conditions occurs this place in the pocket, and you will find the both things. You will find bacteria, you will find inflammatory cells, and due to this fighting, vessel become engorged. So and more vascular occurs there. So you will find edema also there. And also more and more cells, inflammatory cells and bacteria accumulate the sulcus, so automatically it becomes swollen along with the vascular, more vascularity. The degree of leukocyte infiltration of the junction epithelium is independent of the volume of inflamed connective tissue. Thus, the process may occur in gingiva with the slight signs of clinical inflammation. At the beginning, slight signs occurs because just started with the inflammatory reactions. continued inflammation, if you don't treat it or if you don't take any measure to stop this, so inflammation will continue. So then increase the gingival size, bulk increased, and crest of gingival margin extend coronally. So gingiva can be swelled up, gingiva can enlarge and it extend coronally. So you will find deep, pocket depth. The apical cells of junctional epithelium continue to migrate along the root, and its coronal cells continue to separate from it. So apical cell, junctional epithelium, the places the periodontal ligaments. After junctional epithelium, you will find periodontal ligaments, the fibers. So as there is inflammatory condition continue, so they destroy the junctional epithelium, they destroy the initial fibers, periodontal ligament fiber. So automatically the junctional epithelium separated from the tubercular junction. Automatically there is space, more and more bigger space between the tooth and the periodontal pocket epithelium. So you will find more deeper and deeper probing depth. Epithelium of the lateral wall of the pocket proliferates to form bulbous cord-like extension into the inflamed country. So if you see the histological biology, I have some picture later on, you will find that epithelium become proliferated, become cord-like, and it embedded in the connective tissue like you know like this. So that more and more, we call it retipex, epithelial retipex. So it become more bigger and bigger in the periodontium. In the gingivitis, retipex occur, but in periodontitis, more and more become bulbous, more and more. So you will find a invagination of the epithelium inside the connective tissue more and more, and then it crosses the basement membrane. I mean the epithelial connective tissue, the connection. You will find more and more invagination of the epithelium in the connective tissue. Leukocytes and edema from the inflamed inflate the epithelium that lines the pocket, and resulting in various degree of degeneration of necrosis. So as the condition is that they start to destroy the tissue, they start to destroy the vessels there. So degeneration occurs of the ligament as well as other tissues around that. Cement, as a cementum attach the ligament and albumin attach the ligament, so both destroyed. So automatically they separated the tissue from the tooth surface. Early concepts assume that only bacterial attack produce the disease. Early, I mean, long, maybe 20, 30 years before, the researchers thought that the only periodontal bacterial action can destroy the tissue. But after that, gradually it become established that not only by the bacterial action, our immune cells come to fight to each other. You know, I give a simple, explanation always. That মনে করো দুইটা ষাঁড় ফাইট করতেছে, দুইটা বুল ফাইটিং। তো বুল ফাইট যখন হয় তখন দেখা যায় কি ওই বুল যেখানে ওই যে ঘাসগুলোকে মারাচ্ছে না, ঘাসগুলো মারা যাচ্ছে। হ্যাঁ, তার মানে সে যেখানে ফাইট করছে সেখানে লোকাল ফিল্ডটাই সে ধ্বংস করে দিচ্ছে দুজনে ফাইট করতে গিয়ে। তো এই ঘটনাটা ঘটে আমাদের এই ক্ষেত্রে। এখানে our immune cells come to fight with the bacteria, and our immune cells produce lot of toxins, a lot of different types of chemical molecules that want to kill the bacteria, and that becomes sometimes so big that can also destroy it. So this is not only by bacteria, bacterial enzymes, toxins, along with the end products, along with our immune cells and their enzymes, their toxins, and our body, different types of inflammatory, we call it cytokines, they come to fight. So these things also destroy our tissue. So this become now established theory that not only bacteria, our immune cells and bacteria, they fight each other and produce destruction of our periodontal tissues. And you see here mainly polymorphonuclear neutrophils, you call PMN, polymorphonuclear leukocytes, PMN, or neutrophils, monocytes, and other cells. Actually these cells from these cells in our body, in the blood. So these cells come to fight with the bacteria, and these cells produce such enzymes, toxin, and other molecules that can destroy our tissue. Two mechanisms associated with collagen loss. Collagenase, the enzyme name usually with the which tissue they degrade or destroy, যে টিস্যুকে সে ধ্বংস করে তার নাম হয়। So collagen ধ্বংস করে যেটা collagenase. So collagenase is the main part of our collagen is the main component of our periodontal ligaments and fibers. So this collagen they destroyed, so automatically our tooth become separated from the tissue. So collagenase and other enzymes secreted by various cells in healthy and inflamed tissues such as fibroblast, polymorphonuclear neutrophils, macrophages. Macrophages, these altered monocytes. When inflammatory reaction occurs, monocyte come to fight there, and monocyte become macrophage to for phagocytosis. PMN is the first cell. Neutrophil come first to phagocyte the bacteria, but if it cannot, it alone cannot engulf all bacteria, then monocyte come to become macrophage, but more bigger monocyte. It's called macrophage. They also phagocyte, engulf the cell, called phagocytosis process. So both can kill the bacteria directly. They produce matrix metalloproteinases. This matrix, remember, MMPs, matrix metalloproteinases, they produce by the our fibroblasts, polymorphonuclear neutrophils, macrophages. So these MMPs also destroy our tissue. Unfortunate, but these also destroy our tissue. These are only proved. So MMP produce our cells, but they destroy tissue. Why? As because they are fighting with the bacteria. So it can occur gradually when the bacteria and the others become minimized, eliminated. Automatically our tissue response become healing occur. The fibroblast phagocytes collagen fibers. Even fibroblasts, they can phagocyte collagen fibers. This is a really interesting feature in periodontitis. If you go through and through, maybe you will get more and more interesting features in the periodontitis mechanism, how it occurs. This is the start of the pocket, as the pocket is the main feature of periodontitis. So when you go through it, maybe you will get more and more interest. So the phagocytic fibroblast fibroblast can engulf collagen fiber, and they can engulf cementum matrix. That's because cementum matrix also contain fibroblast. Fibroblast is the containing cementum, ligament, and also alveolar bone. These three both they can contain fibroblast. So when they become more activated to fight in the with the bacteria in the inflammatory reaction occur, then they can even fighting with the bacteria in between. They can also just some cell of our body can they can eat. They can eat easily our body cells. So this sometimes become very much deleterious, dangerous for our body. Nowadays what is happening. I just tell you the different aspects, because now we are going with the pandemic situation now with this COVID-19. So this is main cause of coronavirus. This coronavirus produce such a condition in the body that called cytokine storm. So cytokine storm means they just enter the body and they make such a mechanism that our body cells become confused. So more and more inflammatory reaction occur, more and more cytokines produced by our these cells, fibroblasts, polymorphonuclear neutrophils, macrophages, monocytes. Okay, our many other cells that produce different types of inflammatory mediators that want to suppress the antigens virus for the COVID-19. So in this condition, our tissue become produce so much inflammatory cytokines that start to destroy our tissue. This is one of the main feature of the COVID-19 inflammatory reaction inside the body. This is called cytokine storm. This same thing happens in periodontitis cases. So our tissue lost by bacterial entrance, but it lost mainly the action between the bacteria and our host cells. So MMPs, by God, Allah produced such a thing in our body. The matrix metalloproteinases, they come to fight with the bacterial antigen, but they become so active, then sometimes they have to stop it. So again, God prepared another thing. This is called tissue inhibitor metalloproteinases. It means when tissue MMPs become more active, then TIM become, oh, stop, enough, don't do anymore, because you are destroying your own tissue. So these things occur in our pocket inside when destroying our tissues. So MMPs are a group of proteases that play an important role in several biological processes. Like any protease means that degrade protein. They are involved in the degradation of proteins. Specifically, they are important players in extracellular matrix. We call ECM. degradation and inhibited by TMP. So when he started with the MMP action, TMP come and they stop their action, so that our health regained. So cytokines are proteins secreted by cells that interact with other cells and eventually lead to specific cellular response. So we have two types of cytokines. Cytokine means the cell produce some chemicals that come when inflammatory reaction occur. So they mediate inflammatory reaction to gain our health or own healing, any type of owned, as because bacteria enter the body, they produce the owned in our body. So this owned can be healed by starting our body cell mechanism. So they produce such a different types of chemical that called cytokines. These cytokines two types, pro-inflammatory and anti-inflammatory. So lot of cytokines, thousands, hundreds of cytokines are there. I just tell you only 2-3 that is very important for you to remember. Cytokines can be pro-inflammatory or anti-inflammatory in nature. Pro-inflammatory cytokines such as interleukin 1, tumor necrosis factor alpha. Remember these two, very important. Implicated strongly in the pathogenesis of periodontal disease progression. So when a inflammatory reaction starts, then IL-1 and TNF alpha starts to work with the different types of signaling occur. They come here and they start to fight with the bacterial antigens. So they destroy our tissue. And anti-inflammatory cytokines, IL-4, IL-10, they come to stop their actions. As TIMP come to stop MMP's work. Understand? So we have both system in our body, God gifted. So anything occurs inside, our body has the immune mechanism to help regain our health. Okay. Now I'll discuss about the clinical feature of periodontal pocket. Symptoms: localized pain or pain deep in the bone, sensitive to pressure after eating. অনেক লোক আসে তারা এসে বলে যে ডাক্তার সাহেব আমি চাবাইতে গেলে আমার একটা দাঁতে ব্যথা লাগে বা আমার মনে হয় দাঁতটা একটু নরম আমার উইক লাগে। এটা খুব কমন, কিন্তু বাংলাদেশে লট অফ পিপল উইল কাম টু ইউ আর ডেন্টিস্ট, ইউ স্টাডি অল দ্য ক্লিনিক্যাল ওয়ার্ক, সো ইউ ক্যান ডিসকাস, ইউ ক্যান গেট দিস সাচ even sometimes patient cannot say, you can discuss with the patient to know actual history. So talk to them, make a good friendship with the patient to just get the real history. Patient cannot, sometimes they can, some patient কে ডাক্তার আমার এখানে দাঁতের মধ্যে ফুলায় ব্যথা করে এখন you should, if you have the knowledge, the why what type of pain it is, it a pain of periodontitis, is a pain of caries, so is a pain of palpal origin. So if you know the difference of the pain, so you can easily get from the patient's history and you can get initial diagnosis of the case. So sensitive to pressure after eating, sensitive to hot and cold, toothache in absence of cause, even sometimes occur. Okay. Halitosis is very common. Halitosis or bad breath is very common for periodontal disease, and if there's a pocket, you have more and more bad breath. Signs of pocket: bluish red thickened marginal gingiva, bluish red vertical zone, bleeding, mobility, suppuration, diastema formation. So these things are very common. For gingivitis, usually you find the color a red color. But for periodontitis, that you will find the bluish red color. It is different from the color of gingivitis. Okay, so you have to know and you have to practice and you have to be experienced to differentiate with the gingivitis color and periodontitis color. You can see this is the normal gingiva color, is coral pink, but for periodontitis, you see the color is not so much reddened. Little bluish hue you can find, as because the tissue is lost, and the deeper level of the, if you enter the probe, you will find it. You see even this called tooth migration, tooth just shifted from its position due to the periodontitis, because the tooth tissue around the tissue, the supporting tissue structure lost mostly, so it becoming displaced from its original position. This is the clinical feature and histopathologic feature of the pocket. First one, a patient, you see the color is changed, become color reddened or bluish. Why? As because of the distress of gingival fibers and surrounding tissues and a smooth shiny surface by atrophy of the epithelium and edema, and the pitting on pressure by edema and degeneration. So this is the first thing that the degree of bluish red discoloration, you will find for this the cause is here. So left side the clinical feature, right side histological feature. You can easily understand. I think for the color change due to the vascularity will be increased, tissue destroyed, and edema and atrophy of the epithelium. So color become bluish red, not the red color like gingivitis. Less frequently, the gingival wall may be pink and firm, as the fibrotic changes or sometimes occur because sometimes they have relation to the outer surface of the pocket wall. However, despite the external appearance of the health, the inner wall of the pocket invariably presents some degeneration. So degeneration occurs. For this reason, you will find some changes in the external appearance of the gingiva. Bleeding, you can, if you probe it, you will feel, as because ulceration occurred in the subsurface area, in the subepithelium. Actually, for the periodontitis or the pocket formation, you will find the ulceration in the basement lamina. I mean the epithelial connective tissue contact, or the epithelium connects to connective tissue, the ulceration occurs. So if we insert the probe, bleeding can occur from the deeper part. For gingivitis, you will find the superficial bleeding because the ulceration in the gingival, epithelium. When explored with a probe, the inner aspect of the pocket is generally painful. That's because the deeper level of the tissue is injured and destroyed. So if we enter more, you will feel pain, as because the cementum is sensitive, dentin sensitive, and the tissue already bone destroyed. So you will feel more pain than the gingivitis cases. In many cases, pus may be, sometimes pus occur. Pus very common, especially for the diabetic people who suffer periodontitis. Diabetes and periodontitis is very common. It is like cousins with each other. So who suffer from diabetes and uncontrolled diabetes has more and more periodontal disease. So very common pus formation. So you will find some pus exudation from the pocket if you press it, and sometimes patient can say that I feel some salty taste something from the mouth. It come intermittently, not regularly. Now, determination of the pocket depth. How to determine the pocket depth? This is not a simple procedure. You should clearly understood how to it. Now, probing depth, we call it PPD or PD. Probing depth measurement, clinical determination of key loss. You call it clinical loss or clinical level, CAL. Remember this very important point for periodontology to diagnose periodontitis, clinical attachment loss and bone loss. We have to find out from probing the clinical attachment loss, and we have to find out the bone loss from the radiograph. Then this both we have to give. There is a formula to know what type of periodontitis. Either it is a mild periodontitis, moderate periodontitis, or severe periodontitis, according to the findings from this clinical attachment loss and bone loss. So also, you have to find out the suprabony and infrabony pocket by this probing. You see upper pictures, right side. This is the gingivitis case. So if you insert, you measure up to 3 millimeter only. You see, this is the University of Michigan O probe. You can remember this. You see, 1, 2, 3, 4 is missing, and 6 is missing, 7 and 9, 10. So this is millimeter graduations, but in between 3 and 5, 4 is missing. 4 to 7. 6 is missing, 6 graduation. So this is the University of Michigan O probe. Remember, with Williams markings. This is very common probe we use in the clinic. So insert 3 millimeter normal. Here you see it is 3 millimeter, but it is more deeper, as because this is seminal junction is almost open. You can see the yet you cannot see, but you see the bone loss is there. So it is true pocket. Then more and more clinical attachment loss, more loss, as because clinical attachment loss measured from the seminal junction to the base of the pocket. The distance from the seminal junction to the base of the pocket, it is clinical attachment loss. So you can measure from the probing, and you see more and more loss here. The last one. So first gingivitis, second early mild periodontitis, third moderate periodontitis, and third advanced or severe periodontitis. You see the lower portion here. You can measure the pocket depth. How? Clinical attachment loss. First one, you see, this is upper, this is gingival margin, and this is seminal junction for all the seminal junction. Okay, so if you find 6 millimeter pocket, suppose this probe has 3 millimeter graduation, 3 millimeter color, 3 millimeter normal, 3 millimeter color, and 3 millimeter non-color. So 12 millimeter long tip of this probe. Okay, so you see 6 millimeter the probing depth measurement from gingival margin to the base of the pocket. I told you earlier. So gingival margin থেকে base of the pocket, but tip the pocket যেখানে আটকে গেল এই ডিস্টেন্সটা হচ্ছে আমাদের পকেট ডেপথ, the probing depth, we call it PPD or PD. So এটা যদি 6 millimeter হয়, you see, you know the normal depth is up to 3 millimeter. So you have to reduct it or deduct it. 6 minus 3 equal to 3 millimeter is the clinical assessment loss for this tooth. It means gingiva is still covers the seminoid junction. You cannot see seminoid junction. There is no recession. I mean, no visible recession. So when you insert the probe, you will find 6 millimeter. You have to reduce or deduct 3 millimeter, the normal depth. You will find the actual clinical assessment loss. So it means that the formula is without recession, probing depth minus normal circular depth equal to clinical assessment loss. Second one, when there is recession occur, but gingival margin, it comes to the seminoid junction, the same line of seminoid junction. So when you insert the probe and you find 6 millimeter, even 6 millimeter or 5 any, so this case, the assessment loss is the same distance of the probing depth. That's because attachment loss from the seminoid junction to the base of the pocket. So this total is loss from here to here. Okay. Third one, there's recession present. Gingival margin recessed, and you can see the recession, visible recession. Okay. So if you insert and if you find 6 millimeter, the probing depth, as because gingival margin to the edge of the pocket is probing depth, and recession is seminoid junction to the gingival margin. So the two distance you have to make a plus. So for the last one, where recession is present, visible recession is present, it means the probing depth plus gingival recession equal to clinical assessment loss. So three method to measure clinical assessment loss. Okay, remember this. If you can understand, please contact me again. Histopathology, again, initial stage. Changes in blood vessels, morphologic features. I told you earlier. Neutrophils, where polymorphic neutrophils migrate through the walls. So it comes, polymorphic. At first, when you start, the bacteria enter the body and start to produce their enzymes, toxins. Then our gingival tissue, they give, send. Send the signal to the our system. So at first, polymorphic neutrophils, they come and they migrate from the blood vessel. They just pass through the vessel wall and they come to the gingival crevice. So they migrate from the blood vessel to enter the gingival sulcus. Exudation of the fluid from the gingival sulcus and extravascular serum proteins are present. So you will find if the pocket is, already pocket form, then you will find the exudate. If you just take the exudate from the gingival sulcus, we call it gingival clavicular fluid. But this fluid actually contaminated with the different types of bacterial enzymes, toxin, and our end products of the immune cells. So you will find extravascular serum proteins. You will find in this. The gingival sulcus, when become pocket, the more and more bacteria can grow easily, because they are dependent on proteins, that they can easily get protein from the serum. Our GCF is actually, it comes from the serum. So bacteria can easily grow more and more. If you don't care or if you don't take the measure to stop it, more and more destruction occur. Junctional epithelium becomes densely infiltrated by different types of inflammatory cells. And after pocket formation, connective tissue is edematous and densely infiltrated by plasma cell, 80%. Remember this, very important point. Plasma cell, actually, it comes from the lymphocyte. Lymphocyte, we have T cell and B cell. So B cell actually become plasma cell. It become very big of the B cells. So for the chronic cases, as the pocket is a chronic case. Pocket is not accurate. Acute case is the gingivitis. Pocket is a chronic case. So in chronic case, you will find more lymphocytes. So plasma cell will be the 80% in this case. And connective tissue is also edematous and densely infiltrated with plasma cells, approximately 80%, I told you, and lymphocytes, and scattering appears. So in this case, polymorphic neutrophils will be less. In gingivitis case or initial stage, you will find more and more PMN. But in long-standing case, you will find more and more lymphocyte, plasma cell, okay? And neutrophil will be less then. But they're all together. Macrophage also you will find. The blood vessels are increased in number, dilated, encouraged. Particularly in the subepithelial connective tissue layer. Connective tissue layer, যে সেলগুলো, যে আমাদের ভেসেলগুলো আছে, ক্যাপিলারি, সেগুলো এনগরজড হবে, ডাইরেক্ট হবে, more and more blood will come through this. So more and more, so you will see the edema, their color change of the surface of the our gingiva or periodontium. The connective tissue CT is connective tissue exhibits a varying degree of degeneration. Single or multiple necrotic foci are actually present. You will find the varying degree of degeneration in the tissue, in the periodontium. In addition to exudative and degenerative changes, connective tissue shows proliferation of endothelial cells. Endothelial cells means the capillary. That the capillary is inside the connective tissue of the periodontium. So the endothelial cell will be proliferated and more bigger. It become vessel become engorged and become dilated and formed capillaries. Also more and more capillaries will be formed. Fibroblast will come and collagen fibers also. You will find proliferation occurs. So you will find for the periodontitis case, when you longest case, if you touch the periodontal pocket, you will find little fibrotic surface. It is not like a normal. You can just make differences. You can touch a normal gingival tissue and you can touch a periodontitis tissue. You'll find difference. The periodontitis is a little rubbery, not like simple resiliency you get when you touch the normal gingival tissue. So in the base of the pocket, you will find 50 to 100 micrometer the cells. So the junction epithelium destroyed and gradually it become the thinner layer. Usually to a normal 500 micrometer wide or thicker, but in the periodontal pocket formation, you will find 50 to 100 micrometer width of the junction epithelium. The most severe epithelial proliferation and degenerative changes, you will find the lateral wall of the pocket. So periodontal pocket, the lining of the periodontal pocket, it become pathological gingival sulcus, and you will find more and more inflammation there, more and more infiltrate also there, especially the plasma cells you will find in the epithelial lining of the pocket. You see this is the papilla. And actually destroyed, and also you'll find the abundant of the leukocytes and bacteria inside. This is suprabony pocket, okay, and here is the infrabony pocket, and you will find there's a lot of bacteria and grow and they destroy the tissue. You see the tear up of the tissue. You should have a margin, plain margin, but they destroyed. So the tissue destroyed, and you find this teared up tissue. এখানে টিস্যু ছড়ে জায়গায় নাই, তার মানে অনেকটা লস হয়ে গেছে, সেখানে জায়গায় ছিঁড়ে গেছে, সেখানে আরো বেশি ব্যাকটেরিয়া ঢুকছে, আরো বেশি সেখানে ইনফ্লামেটরি রিঅ্যাকশন আছে, আরো বেশি টিস্যু ডিস্ট্রয় হয়েছে। You see bacteria entering the tissue. You see the teared up the area. This is the teared up area, bacteria entering the tissue. Okay, and the collagen fiber destroyed. This the bacteria, this type of bacteria is rods, coccus. We call it coccoid type of cells, and these are rods. You see dots. These are the rods, and some are helical. That maybe this is spirochetes. This is a rod. This is maybe spirochete. Okay. So different types of bacteria you will find in the rods, coccus, and filament. You also filamentous bacteria. Filamentous, the bacteria has the tail or appendage. We call it fimbri, flagella, different types of. মানে যেমন গরুর লেজ থাকে ওরকম আর কি ব্যাকটেরিয়া, ওই ফ্লাজেলা বিভিন্ন রকমের ইয়ে থাকে আর কি লেজের মধ্যে, এগুলো বলে আমরা filamentous bacteria. And you will find many types of coccobacillus. Coccobacillus like the coccoid type. You see this shape? It is not circular, little elongated. It's called coccoid cells. Or you find that more and more deeper level. You see, this is a leukocyte. Suppose EPMN, engulfing bacteria for phagocytosis process. The extracellular matrix and the intracellular space. This is exfoliate epithelium cells. So this happen if you see more and more big. You see 8,000 times bigger picture than the before. So you will find the what is happening inside the periodontal pocket. You see some places periodontal disease or periodontitis is not static. Sometimes it rapidly destroys the tissue, sometimes it becomes static, sometimes healing occur, sometimes more even repair more. So this is episodic nature of this disease. This is a disease of episodic nature, not statically like a pyramid goes the destroy or come healing downwards. No, it does sometimes active, sometimes static, sometimes down, sometimes again static, again increase. So this type of so for this reason periodontitis is very unpredictable. Like now COVID, unpredictable type of inflammatory reactions occur in the body. So periodontitis is now become too much importance to the scientists to know the actually how it produces a lot of disease in the body. So you see this this is the area of quiescence, means area all healed up. Still there is a bacteria is there, they're producing, and you see bacteria and host cell interaction is the C, and D already tissue destruction. So some places you will find less tissue destruction, some places you will find more tissue destruction. So actually it is actually still I mean researchers could not become concluded that how actually tissue destruction occurs, how it become repaired in the same time. So you will find the same condition, one side of the tooth you will find active lesion, another side inactive lesion. This is very common for periodontitis. If you know better, and if you go diagnose the case in the clinic. Here also the same, a more bigger, it is a 1500 magnification. Scanning electromicrograph, periodontal pocket wall, you'll find the advanced. This is severe type of periodontitis. Advanced severe type of periodontitis. You see disc epithelial cells, disc epithelial cells, also bacteria are there. Bacteria, you see, bacteria, the black bacteria are there. So scattered bacteria also seen in black or scattered bacteria. So still this is a condition of that. Some places healed up, some places bad, some places static. So this condition occurred in the pocket. If you see the pocket epithelium, if it's histologically, if you make sections. This is another picture. This is the left side. You see A. Picture A. You see the bone loss is there. This is the, you can see the opaque finish of the line. This is called cemental junction. Cemental junction. So from cemental junction, you have to measure the bone loss. Okay. From cemental junction up to the apex, it is called 100%. So from here to here, this is bone loss about 60% or 55% bone loss for this mesial surface of the first premolar. And second premolar, you will find this is a loss almost 50% or 45%, and you find here is a angular bone loss, here is horizontal bone loss. So if you see a radiograph, you can get a lot of information from there. You can get the bone loss, you can get the bone loss measure, how much is there, you can get the bone loss pattern also. Okay, so these things if you go for histological slides, you will find that what is happening inside. Okay, the different types of conditions occur in different sections. Actually some are myeloconnective tissue stain. This is the number C, and number F, this Mallory stain. This makes a different color, and others are maybe eosin color, HE, hematoxyl eosin color. They make a different color. So you can find the different colors, but you can easily understand. You see the pocket already dressed the tissue from the tooth surface, and also the same. Actually, this is the structure of the same tooth that we showed in the radiograph. The histological sections, you'll find the calculus also present here. Calculus are present here in the subgingival area. Okay, bone loss, tissue loss, and you see the fibers become oblique, and some fibers are lost. Oblique pattern of fibers, you see. So for the angular, you will find oblique. For the horizontal side, you will find horizontal pattern of the fibers. So this is the proof of the radiograph along with the histological feature that what is happening when there is a pocket formation. So how to bacterial infection in the pocket? Filaments, as I told you, filamentous bacteria that has a appendix or fimbriae or flagella. Rods and coccoid organisms with predominant gram negative. Remember, gram negative usually the color is pink or red color. When you do gram staining of the bacteria, for the gram positive you will find the color bluish color, violet color. Okay, for gram negative, pink or reddish color gram negative bacteria. It is depending upon the actually bacterial cell wall pattern. So bacterial cell wall for the gram positive, it takes the color bluish or violet, and for the negative they take the color usually reddish or pinkish color. So you will find this mainly Porphyromonas gingivalis, we call it PG, and pivotal intermediate we call it PI, and aggressive periodontitis. Aggressive periodontitis, I give another lecture inshallah. Aggressive periodontitis is a condition that occurs in the early age, and there are a lot of without knowing the cause, lot of destruction of the tissue occur for the periodontium, and more and more angular vertical bone loss you will find. So in this case you will find more and more PG and PI, and also A, aggregative bacteria, Actinomycetum comitans. This is a very common bacteria you will find in the periodontal pocket. Remember this. Bacteria may invade the intercellular space under exfoliating epithelial cells. The bacteria can invade us because when the bacteria started to make the plaque, so plaque bacteria starts to produce the inflammatory reaction. Then there's a tear up of the epithelium intercellular space. So tear up occurs due to epithelial destruction. So bacteria can invade in the tissue and they can enter in the deeper and deeper layer of tissue. So for the periodontal pocket, you will find bacteria in the basement lamina. It means you will find the the epithelial has 4 layers. Sternum corneum, sternum spinosum, basally, okay, is a intermedium. So they enter this all the piers and go to the basement lamina and enter the connective tissue also, the bacteria for the periodontal pocket. And the presence of bacteria in the gingival tissue has been interpreted by different. So this bacterial invasion, so when bacteria entered the basement lamina or in the connective tissue of the periodontium, the researchers can call it bacterial invasion or passive translocation of plaque bacteria. Plaque bacteria usually should be along the gingival margin, but when you find the bacteria inside the tissue, it causes passive translocation of plaque bacteria. Remember, this is a very important term to know. What is passive translocation? Passive translocation of plaque bacteria means bacteria entered in the deeper layer of the tissue. It means it crosses even the basement lamina of epithelium and enter the connective tissue. Now, pocket, what is the pocket contents? Pocket, what is the pocket contents of macroorganisms mainly? What macroorganisms they can do? They produce enzymes. There was proteases, trypsin-like enzymes, matrix metalloproteinase, etc. It's a lot of, they can produce different types of enzymes. Endotoxins they produce lipopolysaccharide. It's called LPS. Leukotoxin, this produced by bacteria, and other metabolic end products. Suppose after bacteria take food and they excrete, like as a man আমরা তো পেশাব পায়খানা করি, ব্যাকটেরিয়া গুলো করে যেগুলো বলে মেটাবলিক এন্ড প্রোডাক্টস, এগুলো যেমন অ্যামোনিয়া, হাইড্রোজেন সালফাইড, মেথাইল মার্কেপটেন, ডিফারেন্ট টাইপস অফ তারা প্রডিউস করে। এগুলো কাজে ব্যাকটেরিয়ার 3 ধরনের জিনিস ক্ষতি করে। একটা হচ্ছে ব্যাকটেরিয়া নিজে এনজাইম দিচ্ছে, যে এনজাইম দিয়ে সে টিস্যুকে ডিগ্রেড করে সে খাবার চায়, প্রোটিন সে নেয়, প্রোটিনকে সে ভেঙে, প্রোটিন তো পলিপেপটাইড চেন থাকে, সেই চেনটাকে ভেঙে সে অ্যামাইনো অ্যাসিড নিয়ে অ্যামাইনো অ্যাসিড গুলো সে খায়, কারণ ব্যাকটেরিয়া তো সিঙ্গেল সেল, দে ক্যানট টেক মোর বিগার সাইজ অফ food particles, so they can take only unit of the protein, especially for the periodontal pocket. For carries they take saccharose, take carbohydrate or fructose, glucose, that is saccharose, but here they take amino acid, So this amino acid, they just tear up, they just break the chain of the polypeptide. Suppose they have trypsin actually cut the peptide chain, and protease they just cut the peptide chain to become a smaller peptide, maybe 1 or 2 amino acid. This peptide they can take bacteria, so they produce enzymes for the nourishment. And endotoxin is because they just want to kill our immune body cells, so they produce lipopolysaccharide. This is very destructive type of endotoxin produced by the bacteria. Suppose Proforma gingivalis, they produce such a Fusobacterium nucleatum, they produce such endotoxin, lipopolysaccharide. They're encoded with the gram-negative bacterial cell wall, so they produce the endotoxin to kill our leukocytes. As the leukocyte come to fight with them, to engulf them, so they produce such endotoxin. And also they produce leukotoxin, directly kill the leukocytes. And other metabolic products, as I told you, they produce after taking food, they just excrete. So 3 types of bacterial products you will find in the periodontal pocket, and you can easily find out if you just take the GCF of the pocket and analyze the lab. You will find the different types of marker. Suppose you find more LPS, it means more and more disease. You find more protease, it means the more periodontitis is there. So less of these enzymes, toxins, and metabolic end products means less disease. More of these markers, more disease. Remember this. And also there you can find dental plaque is there, gingival fluid, food remnants, salivary mucins, as because our saliva contains mucins, so you can get salivary mucins, discovered epithelial cells and leukocytes, And because the epithelial cells are destroyed and they're excavated from the cubicular epithelium or sulcular epithelium, and that you can find in the pocket content. The leukocytes, there are a lot of leukocytes you will find polynuclear neutrophils, and also mostly you will find the lymphocytes. If pus is there, you will find living, degenerated, necrotic leukocytes, serum, and scant amount of fibrin. The contents of periodontal pockets, sometimes you will find the debris. They are very toxic. This is an animal experiment. If you take the pocket, content, and you kill all bacteria, just you take the pocket content and insert in the any animal body, you will find that the tissue destruction occurs. So animal experiment showed and confirmed that the pocket contents are destructive for human tissue, and because they destruct the animal tissue without the bacteria. No bacteria there, only you took the GCF and you kill bacteria and just took the fluid part and inject in the animal, the tissue destroyed. So this is the proof that our pocket content are so deleterious, are so noxious. We call it noxious products. The surface morphology of tooth wall. The following, you will find 4 zones, actually 5 zones. If we just see histologically of this of the pocket. Cementum covered by calculus, the topmost layer. Attached plaque, second layer. It is 100 to 500 micrometer width. Zone of annulus plaque, usually attached plaque and extend apically to it. After the attached plaque, then you will find annulus plaque. The zone of attachment of the junction epithelium to a tooth. So you will find another attachment of junction epithelium to tooth. Junction epithelium will migrate to the root, towards the apex, towards the root, and you will find the more than 500 micrometer is far from the reduced from the periodontal pocket. So as I told you earlier slide, that the junction epithelium usually it is up to 500 micrometer, but for the inflammation of the condition, the junction epithelium become destroyed. So you will find maybe less than 100 micrometer width. And zone of semi-destroyed connective fibers may be apical to below junction epithelium. You will find semi-destroyed connective fibers. And note that you will find here zone 3, 4, and 5. You will find this plaque-free zone. Attached plaque is there, but after that you will find unattached plaque. And unattached plaque actually contains gram-positive and gram-negative morphotypes and cocci, rods, filaments, fusiforms, and spirochetes. And most apical zone you will find gram-negative rods and cocci. Remember this. A different zone you will find different types of bacteria. Mainly in the pocket you will find gram-positive anaerobic rod, but gram-negative also there. Mainly you will find in the deeper layer gram-negative anaerobic rods and cocci also some, but mostly you will find gram-negative anaerobic rods. You see the different zones are showing. The first zone, cementum covered by calculus. This is attached plaque, unattached plaque, junction epithelium is there. It becomes the wood becomes well. Then partially last the connective tissue fibers lost here, and then intact after the intact still. This place, the lower part is still is healthy. Upper some tissue fiber. So this is the 5th zone. So 1, 2, 3, 4, 5 zone you will find in a periodontal pocket. Periodontal disease activity, early concept that loss of attachment produces periodontal disease was thought to be a slow by continuous progressive phenomenon. Early, it means as I told you that the periodontal disease concept that they thought that before 30 years, 40 years, they thought that it caused by bacteria and it slowly it just destroyed. But now it become changed. Before 30 years, it become a change that the concept that now the destruction occurs due to the bacteria and our immune cells reactions. So here another thing, as I told you, that is not static, episodic nature. So sometimes periods of exacerbation, sometimes it is very actively destroy the tissue. It's called period of exacerbation. Sometimes you see this is the healing up, repair tissue. It's called quiescence. So these 2 types of periods you will find in the periodontal disease progressing. Disease activity progression. So once you can see the periods of exacerbation and the periods of quiescence. It means sometimes it become normal, sometimes it become more active. Periods of quiescence, the reduced inflammatory response, little or no bone loss, connective tissue attachment. Okay, no loss of connective, little or no. This is a period of quiescence. And exacerbation means build up unattached plaque, more and more. Swirling plaque, more and more swimming plaque you will find in the pocket. And gram-negative bacteria and motile rod you will find, anaerobic bacteria, spirochetes, and also more and more bone and connective tissue loss you will find. So you will find more gram-positive bacteria for the period of quiescence. For period of exacerbation, you will find more gram-negative and motile rods, anaerobic. And active periods show bleeding. You will find the bleeding more for the active phase of the disease. And greater amount of also exudate. Maybe GCF will be more increased. You know, the GCF normal amount, it will be increased in case of pocket formation or periodontitis. And histologically, the pocket epithelium appears thin and ulcerated. As I told you earlier, why there is a pain, why there is a bleeding, due to the pocket epithelium become thin ulcerated due to the enzymatic and toxic the activities between the bacteria and the host cells. So you'll find more and more plasma cells, and PMN will be there in the predominant. Plasma cells about 80%. Remember this. Site specificity, some places site, some site I told you before, আমি তোমাকে বললাম কিছুক্ষণ আগে যে একটা সাইডে দেখা যাচ্ছে যে খুব বেশি অ্যাক্টিভিটি, আরেকটা সাইডে অ্যাক্টিভিটি কম অথবা নাই। এটাই হচ্ছে পেরিওডন্টাইটিসের একটা মানে আনএক্সপ্লেনেবল সিচুয়েশন টিল টুডে। এখনো রিসার্চাররা বলতে পারছেন না যে এই ঘটনা কেন ঘটে, যে একটা দাঁতের একটা সাইডে দেখা যায় ডিপ পকেট, আরেকটা সাইডে পকেট নয় এবং হেলদি নর্মাল টিস্যু। দিস ইজ রিয়েলি I mean amazing, or this may be astonishing thing, that surprising thing that you will find the periodontal disease. So this is called site specificity. Site specificity means some site are more active, some are no. So it's called site specificity. So active site has more destruction, and quiescent site less destruction or no. So severity of periodontitis increases the development of new disease site. So if you find more and more active disease, more and more new sites, so it means more and more disease occur. It means more and more severe of disease. Pulp changes associated with periodontal pockets. Sometimes our pulpal tissue can be also affected by this pocket formation, as because you know we have you know a lot of tooth, they have accessory canals, they have lateral canals, you know. So even sometimes if there is a cemental tear, then bacteria can pass through the dental tubules to the pulp. So there's a lot of ways that endoperiolation can occur. We have a chapter in the more, maybe you will find it later on. Endoperiolation, when periodontal structure destroyed and bacterial plaque is there, I mean anodous plaque, you will find in the periodontal pocket. So these bacteria can enter through the dental tubule, and that can affect the pulp and can produce pulpitis, pulp hyperopnia, very common. And also if there is any accessory canal opening in the periodontal pocket, so bacteria can easily pass through this. So this is the condition can, and this condition actually may produce atrophic and inflammatory pulpal changes occur. Okay, so there are three ways to enter the bacteria to the pulp from the periodontal disease or pocket. One is if the cemental tear and dental tubule open, bacteria can pass through. Second, if the accessory canal, through the accessory canal, bacteria can go through to the pulp. And third one, if the periodontal pocket extends up to the apical foramen. So if the pocket extends up to the apex, then retrograde way bacteria can enter the pulp. Okay, the three ways bacteria can enter, and that any condition bacteria can enter the pulp from the periodontal condition, it called atrophic and inflammatory pulpal changes can occur in the pulp. The severity of attachment loss, pocket formation is generally but not always correlated with the depth of pocket. This is the thing, is that attachment loss and bone loss to pocket depth. So attachment loss, as I told, attachment loss how to measure I showed you before, and bone loss I didn't tell you yet, as because we have another lecture for bone loss and pocket depth. So sometimes you will find the less pocket depth but more bone loss. Sometimes attachment loss is more but less bone loss. Attachment loss is more but pocket depth shallow. So this condition occurred, several conditions I'll show you so that you can understand other than my description. You see, this is normal, it is up to 1 millimeter. Oh no, it is the 3 millimeters, because almost 3 millimeters. So you can think because still the junction epithelium attached to the cemental junction. This is a normal condition. But when there is already junction epithelium migrate apically, it means it is a true pocket. That's because it just, this is the already attachment loss occurred. Okay, and this is more and more tissue lost, and already recession you will find. This is from here to here is recession, from cemental junction to the this place is recession. So recession, and this is the pocket depth. So recession plus pocket is more attachment loss, but probing depth is still the same. So three conditions you found The 3 disease condition. Okay, so this condition is maybe moderate periodontitis disease, severe periodontitis, or advanced periodontitis. Another thing you see, this is pocket is there, same depth, same attachment loss, but this the gingiva covered the seminal junction. See, in this case, you have to measure how? You have to measure the pocket depth from margin to the bit of the pocket. This is the pocket depth, and from there you have to reduce how much? Deduct 3 millimeter normal. Then you will find the clinical attachment loss. In this case, you have the recession is there, but you see probing depth is a shallow pocket. Shallow pocket. So in this case, this is the recession. From here to here is the recession, and from to here is the pocket depth. So pocket depth of recession, the attachment loss. And here is a, you see, almost pocket depth is nil, maybe 0.5 millimeter, but you have to add it for attachment loss. So attachment loss is the same, but the condition is different of the gingival probing depth. So probing depth always cannot say that this is the condition of the periodontitis. You need to know the clinical attachment loss, most important. So you have to measure the clinical attachment loss to know the what type of periodontitis it is, mild, moderate, or severe, along with the bone loss. So area between base of the pocket and alveolar bone. And normally the distance between the apical end of the alveolar bone will be constant. Usually you will find in the normal cases the junctional epithelium position, usually in the radiograph we think that the junctional epithelium at the point of the crest of alveolar bone, and usually it is the whole life it becomes static. Maybe tissue loss, maybe bone loss, maybe we have recession is there, but usually junctional epithelium and the crest of the alveolar bone, it is a constant distance. Even for the periodontal disease also, if there is a loss of tissue, you will find you see distance between the apical extent of calculus and the alveolar crest in human periodontal pockets is most constant. Remember, very important, very interesting point. Tissue loss is there, but still the below point of the calculus and the alveolar crest, the depth is constant. Almost it is 1.97 millimeter. This is this you don't need to know it as, because this is the thing of the standard deviation, that after making many cases for the analysis of the analysis, we make it a plus minus standard deviation. Just 1.97 millimeter in average from the even the pocket, 1.97 millimeter from the calculus to the alveolar crest. Remember this. Relationship of pocket to bone. Infrabony pockets, the base of the pocket is apical to the infrabony pocket. I told you, infrabony pocket means the pocket extend inside the bone. The bone loss such a way that there is the alveolar, angular or vertical bone loss. And for suprabony pocket, the bone loss in a horizontally manner, and always you'll find the pocket is above the bone. Periodontal pocket has healing lesion. Pocket are chronic inflammatory lesion and does constantly undergo repair. So periodontal lesion is a chronic lesion. So sometimes repair occurs, sometimes restoration occurs. So it is episodic in nature. So never periodontal disease, periodontitis never, healing completely, as because some bacteria always persistence, as because if you do scaling, root planing or anything you do, so still bacteria can reside inside the tissue, as because these bacteria don't need oxygen, they can grow without oxygen, and they take only blood products, they take proteins. So they don't need our food that we take regularly, carbohydrate, protein, fat, etc., etc. They don't need. That need only by supragingival bacteria that they produce carries. But periodontal pocket bacteria, they need only proteins, and they don't need oxygen. Okay, so they can survive long years inside your tissue. So it is very difficult to remove all bacteria, eliminate all bacteria from the periodontal pocket. So usually periodontal pocket or periodontitis doesn't completely repair whole life. So but sometimes you will find that active lesion, but some places also some repair occurs. So complication related to periodontal pockets, periodontal abscess, it is very common, as because due to the pocket deepening, sometimes as I told you, repair occurs. So maybe sometimes some portion of the pocket it become attached with the tooth, and the lower portion become like a pouch, থলের মতো হয়ে গেল, যেখানে ব্যাকটেরিয়া আছে,
যেখানে তোমার ওই এন্ড প্রোডাক্ট গুলো আছে, যেখানে তোমার তো ওইগুলো তখন দেখা যায় ওগুলো পাস হয়ে তখন ওগুলো বেরোতে চাইতো, কারণ যখন পকেটটা ওপেন থাকে তখন কিন্তু সহজে ওগুলো এক্সুডেট বেরোয় আসতে পারে। যখন কোন একটা অংশ আটকে যায় টুথের সঙ্গে, তখন মাঝখানে একটা থলির মতো পকেটের মধ্যে পাউচ তৈরি হয়ে যায়, তখন ওইটা কিন্তু আটকে যায়, তখন ওইটা প্রেসার দেয়, ওখানে তখন পাস ফর্ম হয়। ওই পাসটা তখন ওই যে সাইডে তখন অনেক সময় ফিস্চুলা হয়ে বের হয় বাইরে দিয়ে। এখানে ফিস্চুলা দেখা যাচ্ছে না, এটা অ্যাকুট পেরিওডাল অ্যাবসেস বা ক্রনিক পেরিওডাল অ্যাবসেস, ইউ উইল ফাইন্ড এ ফিস্চুলা that continuous exudate বের হয় আর কি। So this is very common for periodontal pocket to produce periodontal abscess. Now how to treat it? Treatments depending on the type of the pocket. কি ধরনের pocket? Either a periodontal pocket, true pocket or false pocket. We have, two types of pocket are there. It is the general classification. And compound complex pocket, it is related to a true pocket. That is not related to pseudo pocket. So if it is a gingival or pseudo pocket, you do at first non-surgical therapy. You have to do scaling, root planing, and then reevaluation after 3 weeks or 4 weeks. You just take a reevaluation. You have a chart, periodontal chart. Every time when patient comes, you just make your chart fill up. Okay, plaque index, gingival index, mobility, probing depth, recession. Okay, furcation involvement, clinical adjustment loss. Okay, every time you do it and treat it. After treatment, after 4 weeks, call the patient for a recall visit. So again, you make the chart, and then you can compare whether the condition become good or bad or static. Okay, as because patient has to take care at home with the oral hygiene care, you have to instruct the patient how to take care at home. So these things you have to measure every time. So revolution maintenance, but if the pocket is still more than 5 millimeter, usually we'll tell it clinical adjustment loss more than 5 millimeter still, then you have to go for surgery. And usually for the pocket, we do gingivectomy or gingivoplasty. But nowadays we just change the because gingivectomy, it cut the tissue, so maybe tooth become exposed. So nowadays we do mostly flap surgery. We have another more sessions to discuss about this. So these are the main, treatment policy for the periodontal pocket. Okay, remember this for your exam. Treatment of periodontal true pocket. True pocket. If it is periodontal pocket or true pocket, it means junctional epithelium migrate apically. Junctional epithelium not attached to the single junction. It is destroyed and it apically migrated. Okay, and it width also less, maybe less than 100 micrometer. So at first you have to do scaling, root planing. We call SRP. Remember, very common term. This is called non-surgical therapy for periodontitis. SRP. For gingivitis, you have to do scaling and polishing only, and oral instruction. For periodontitis, it means pocket is there. You have to do scaling, root planing, and polishing. Remember, this is for the periodontitis treatment plan. Reevaluation maintenance and removal of the pocket wall by surgery. At first, we can do gingival curettage. Curettage is a procedure, surgical procedure. First, we just blindly just remove the pocket wall by the curate. Okay, and also we can do it by surgical blade. We call excisional new attachment procedure. Procedure is also curettage, but it is called ENAP. ENAP, excisional new attachment procedure. This is also curettage, but we use blades other than curate. If it is still not solved, still pocket more than 5 millimeter or more than 5 millimeter, then we have to go for surgery. Or sometimes maybe with a deeper pocket, maybe one root we can extract, just maybe a multi-rooted tooth, one root can be resected, we call root, or you can just make for the lower molars, make it hemisection, we can make bicuspidization. Okay, I mean, if you see the pockets are furcation involved and we cannot treat it as well, so we can make it two part of the tooth, and then every root become a single bicuspid, I mean premolar. Okay, so there are a lot of ways we can save the tooth. Root resection or hemisection, we can save the tooth by this way. And for suprabony pocket, SRP is root planning and maintenance. Both anterior posterior both the same, but if pocket persists, we have to go for flap surgery. The same. For anterior and posterior, nowadays we do flap surgery. Nowadays gingivectomy is very uncommon, and also gingivoplasty we do sometimes after especially necrotizing also gingivitis. Necrotizing also gingivitis, that the destroy our gingival papillae. So in this case we do gingivoplasty. But nowadays actually mostly flap procedure or flap surgery is most common to just save the tooth and give the aesthetic structure of the periodontium. Infrabony pocket, you see the pocket, you see how it is. So this type of pocket usually need regenerative therapy. So we have to just remove all debris, granulation tissue, necrosed cementum, necrosed bone, everything just become you just reopen the healthy tissue, remove all pathologic tissue. Okay, then you can use bone graft material. You can use platyl-rich fibrin also with the membrane. So different types of procedure we have for the surgical
to just repair this type of defect. It's very deep vertical defects of the bone loss. Okay. So these are the things we discuss about today. Thank you so much for your patience hearing, and I hope that it will help you for your study periodontology, and it will be good. I mean information that it can help you for the exam also. I use mainly Newman and Karanja's Clinical Periodontology, 13th edition, 2019, chapter 23. Page, this is the page. So if you can get it from internet, or you can try to find it this, and also I just use some pictures I took from the internet. And my disclaimer, I just disclose that I have no financial relationship with this presentation. This is purely educational purpose, and no financial benefit or any other type of benefit involved with this presentation. Okay, so thank you so much, and we hope to see you again in next week.